Good morning, and welcome to Let's Talk SADS Live, the Canadian SADS Foundation monthly webcast. I'm your host, Dr. Shu Sanitani, and delighted to be coming to you from Vancouver this morning and reaching you wherever you are catching up on your podcast and webcast listening. Excited to be here and have a great show for you today. Episode 35, and we're going to be talking about long QT syndrome. So before that, I just want to thank some of our sponsors, Lexio Therapeutics, Solid Biosciences, Tenaya Therapeutics, Thrive Therapeutics. And you've heard me talk about the importance of what these companies are doing in the SAD space, sudden arrhythmia death conditions, and these companies are exploring new treatments and new molecules, gene therapy, much more personalized approaches. And so we're very grateful for our partnership with them and their support of what we're doing at the Canadian SADS Foundation. And today our webcast really is about learning together collaboratively, patient and provider together, and talking about these conditions. Our executive director, Guido, has been doing a great job of getting the word out, and now we are available on all these platforms, and you'll recognize those icons, and you can listen to the webcast on any of these at your leisure and convenience. Well, September is upon us, and it's got that back to school feeling. It's certainly been a bit of that back to school weather and traffic. So a good time to refresh your safety kits and your back to school plans. A lot of advocacy around AEDs, automated external defibrillators in schools, and CPR awareness. And that's one of the missions of the Canadian SADS Foundation really is to promote awareness of SADS conditions and life-saving measures as simple as CPR. And so check out the website and refresh your refresh your safety plan. Exciting changes are coming. You all know that we had Guido McGuigan join us earlier this year, taking over the very capable leadership of Pam Husband, who really founded the Canadian SADS Foundation 25 years ago and more. And so we're excited. Guido's been working closely with the board and our stakeholders and has some great things coming. So today's guest really needs no introduction, especially in the Canadian SADS landscape, but really in the international landscape. Dr. Andrew Krahn is a professor and former head of the Division of Cardiology and has really led every major society in the heart rhythm space, including the Heart Rhythm Society and the Canadian Cardiovascular Society. So let's bring Dr. Andrew Krahn in and catch a bit of his journey and lots of insights into long QT syndrome. So welcome, Andrew. Thank you so much for joining us this morning.
Well, thank you very much, Hugh. It's great to be here and have a chance to chat about long QT and where we've been and where we're going.
Absolutely, and I love that your identification, Andrew K. HiRO founder, and we'll definitely talk a bit about that this morning. So, as you know, I always like to let our audience know a little bit about, who's in the hot seat, and I know many people have listened to you talk, seen you at conferences, read your manuscripts, but give us a little bit of your background and how you really have come to be, I want to say, the most known Canadian SADS clinician.
Well, that's very kind. I'm not sure about that, but I think my story goes back to I went to medical school and did much of my training in Winnipeg, and then moved to London, Ontario, which was an area of heart rhythm expertise. It was on that sort of short list of founders in this field. And I was finishing my training in the early 90s. And so that's a long time ago. And I was sent downstairs to where we do exercise or treadmill tests to supervise 2 young boys. So Trevor and Derek lost their grandmother shortly after their grandma gave birth to their mom. And looking at their EKGs showed QT prolongation. And you've got to remember at that stage, there was no recognized genes or genetic testing for long QT. It was, in early days, as it were. And I asked my boss, said, what am I looking for, or what do we do, or how do we interpret the test? And the short answer was, we don't know. We know the EKGs looked like long QT, but we didn't know how severe it was, what treatment was necessary at the time. There was the beginning of the beta blocker conversation happening then. And one of those 2 boys' EKGs, it was such an inception moment for me to say, I want to figure this out. This is very fascinating. And what a terrible tragedy to never get to meet your grandmother. And so Derek's EKG actually is blown up, laminated, and behind my desk in my office, because it was such a aha moment to say, we've got to figure this out. So the reason I tell the story is because as this unfolds and we're going to have this conversation, it became pretty clear that these kinds of rare conditions, they weren't well understood by me. We didn't know genetics at the time, but the only way to really understand this was to work together. And then we'll talk about how you and I became friends and how this has really grown across Canada in the last 30 years, and what I think is a really, really great Canadian message.
Yeah, and I love hearing that story. You and I, of course, have shared that story previously, and just the whole the unraveling. And I was training in that sort of mid 90s where the reports of the genetics of long QT were coming out, and I remember it being so exciting for those of us who were watching this, and of course it was the beginning of a total, I would say, a revolution of how we do healthcare, really. So nowadays we have, people are going off and doing special training in inherited heart rhythm. What did your training? How did you become, a SADS expert, a long QT expert? Was it sort of a DIY situation, or?
Well, I mean, I think if you go back to, you'll recall, where the state of the field was back in, the first real collective description of this was in the very late 70s with an international long QT registry, led by 2 people who, are real founders in the field. But as you might expect, they were bringing together a very severe group of people with long QT who were then referred to these epicenters in New York and Italy to try to bring together that experience. So when you looked at the literature, the publications and the description of that population and so on, that's how you, if you like, got up to speed for what we know. But I think if you understand where we're at now, a lot has been learning on the job, DIY, as you say, because much of what's happened with understanding long QT and the genetics and the clinical findings and the best treatments and those things has basically unfolded over the course of that period.
Now, let's just remind our audience, and many of our audience are familiar with long QT, but just give us the kind of the basics. What is QT? What is long QT?
Yeah.
What are we talking about? Why is it dangerous in some people?
Well, the people who have met me, particularly in a clinical setting, will know I have these quirky little stories and analogies, and this is one of them. So I tell people that the heart's a pump. It fills up and then pumps the blood out, and it's a little bit like a toilet, believe it or not. So, a toilet fills up slowly and then pumps quickly, flushes quickly. And so what long QT is it's measuring how long it takes to flush the toilet and have the toilet get ready for the next flush. And with long QT, it takes longer than normal for the pump to fill up the toilet to be ready for the next heartbeat. And if you've ever tried to flush a toilet before it's finished its cycle of things, it can stick, it can flutter. And if it does that, and it takes longer than usual, let's say it takes 10 seconds, then what happens is your heart's not ready, your heart stops for 10 seconds, and then you faint. So if you've had if you've been in that setting or you're curious, the doctors are very curious about fainting episodes because those can be warning signs. On the other hand, if it sticks until you come and lift the top off the toilet and hit the thing in the back, that's kind of like you're stuck without a heart rhythm, and then you collapse or you have a cardiac arrest. And when that happens, then you need somebody to come along and hit the button. And that hit the button is an AED or a defibrillator or CPR, something to get you back. And sadly, if that happens in a context where no one comes along, the heart never starts again. And then we lose the person. And so what those doctors are so, I would say, somewhere between fascinated and obsessed with is measuring how long it takes for the heart to get ready for the next heartbeat. That's my kind of lay analogy in this situation. And so when we do things like genetic testing, for example, we're reading the blueprint of the little pump in the toilet to see, and people with inherited long QT there's a typo in that script for making that pump. And so then it takes longer. And we know that the longer it takes, the more likely something like a simple skip beat can come along and then cause the toilet pump to stick. And so we're very preoccupied with measuring how long that takes. Because we know that the longer it is, the more risk there is of one of those kinds of events.
The toilet analogy is great, and I'm sure it really is something people understand quite readily. And of course, we're talking about the electrical system, really. So it's maybe like a very sophisticated toilet, and then we somehow are electricians as opposed to plumbers. But anyhow, and then you in your early work, especially, you really focused a lot on the diagnosis and in particular the exercise test. So how does exercise play into this, this condition and diagnosing it especially?
Yeah. So one of the things, I think, if you go back and look at the original description of long QT, if you were able to get yourself or your information, to Art Moss in New York or Peter Schwartz in Italy, it meant you had bad enough long QT, you got people's attention. And so those were people with fairly severe long QT. And that's something we need to both respect and be very careful with managing. When we look on a broader basis, though, at all of the people who have long QT, and that involves the person where it's identified, but also their family members, half of patients who have long QT don't have a particularly long QT interval. And another quarter of them, their QTs are really kind of borderline. So it's not, in lay terms, it's not a slam dunk diagnosis about 3/4 of the time. And so part of my interest at the beginning was sparked by that index story I told you. And the question really about how do we, if you like, bring out the long QT? Do they really have it? How can we see it? And of course, this started before there was genetic testing. So we couldn't just, do the genetic test, see if they've got it. It was the question, what happens with long QT? And Shu, you'll know, when you talk to long QT patients and their families and ask them, have people fainted? What was happening if somebody had collapsed and had a cardiac arrest? The circumstances are a little unusual. They're strong emotion, middle of the night, a loud noise, during exercise, the kinds of things where people don't usually faint. And so then you can imagine that sitting there having an EKG is not the environment where the long QT really shows up. And so then the question was, how do we make something happen? How do we have the long QT show its hand? And so the easiest way, which again goes back to those two young boys, was to do an exercise test, because then you have the heart at least speeding and slowing. And then the question is, does the QT kind of keep up? Think of it as, if we're going back to flushing the toilet, as the heart speeds up, then it flushes faster, and then it fills faster, and so on. And so it should do that. And we're very busy measuring those intervals, how long it takes for that process to happen on the EKG. And I'm a bit of a slow learner. It took me a little while to realize, about 10 years of taking all these measurements with the unfolding of genetic testing, that the QT changes we see with exercise are useful about actually 90% of the time, unlike the EKG, which is usual about 50% of the time. And that the different genetic types of long QT actually behave differently. So, there was an era where genetic testing took a long time and was hard to get. And I was about 80, 90% accurate in not only telling you if you had long QT, but what kind you had, because I had been looking at this for a long time. And so then we ended up describing, if you like, the cutoffs and what numbers to measure and so on, and brought it down to something that most people can use quite simply. So if you hear people talk about this, although all the different things on an exercise test are helpful, the simplest thing to do is, after you're finished, lay down, wait 4 minutes, and do an EKG. And that's helpful about 90% of the time.
Yeah, and that work, I mean, really, I'm amazed at accuracy, because it is so difficult in some of the the young people, especially. I find they'll have a normal ECG at rest, but with exercise, everything changes, and we've definitely made some diagnoses based on exercise alone when they have either a family history or a genetic risk. So your early work on describing the different responses is something that many of us go back to. So beta blockers is something that's always of significant interest to our families, especially, and healthcare providers often will call us up and say, can I reduce the dose? They're tired, and that. We spoke a bit at the opening about all these wonderful sponsors who are working on better treatments. In the current state, are all your patients with long QT syndrome on beta blockers?
Yeah, it's a very good question. I think if we go back to the work that was done that showed that, and it's really what you call association research. So if you put somebody on beta blockers, it prevents that sort of adrenaline speeding of the heart that is part of the toilet not being able to keep up, if you like. And so it makes sense that you would have everybody put on beta blockers. But the whole aspect of how bad is their long QT, how badly do they need the beta blockers and so on, is based on just doing an EKG. And we already talked about the fact that that's not necessarily what's happening out there when somebody's heart's speeding and slowing and has different environment and stimulus and emotions and activity and stuff. And so, I think our literature would suggest that if your QT isn't very long, your risk is very low, and maybe you don't need a beta blocker. But you and I know that when you put that person on the treadmill test and you look at their heart speeding and slowing, you often see EKG changes. You see the QT get longer, and you go, oh, there is some risk. It's just not there when they're resting, but it is more so when their heart's speeding or slowing. So I err on the side of advocating for beta blockers in all long QT patients. And there's a couple of reasons. So one is the worst case scenario on the one hand is somebody who, again, their EKG isn't too striking, but when they suddenly, for example, are scared, they're running to catch the bus, they have a bad dream, they get into a fight, the kinds of things that can happen they're not the things we're measuring for whether there's risk there. I think the second thing is another illness can come along, and that can make their QT problematic too, when they have infection or diarrhea or some other biologic stressor that makes their QT perhaps more likely to act up. And I think the other one is and I'll just give an example, it's the family context. So let's say, for example, you have a young teenager who faints at school, and then they have long QT, and then they get checked, and then they get put on beta blockers, and they don't like it. They don't like taking pills. They don't like feeling tired, and so on. And we'll talk about how to manage that. But the long and short of it is that then, mom and dad get checked, and then grandma and grandpa get checked. And then turns out grandma or grandpa has it. I mean, it's typically inherited, right? And grandpa's sort of an old curmudgeon cynic and says, well, listen, if I've had this all my life, I don't really have it because it's never bothered me. And, you just tell me I have this, but I'm not sure I even believe you. And then I say, well, are you worried about your grandson? And we'll say, well, of course I am. Well, what kind of message do you think it sends to him if you're not willing to take the same pill he has to take for your long QT? When you take him out bike riding, do you wear a bike helmet? Right? Because you sure would insist he does. So I think there's also that social message of we're all safe kind of thing around beta blockers. And we'll talk about how to make beta blockers easier to live with, if you like. But I do feel strongly that most patients are suited to beta blockers. But the good news is more and more research is ongoing to look for patients who have sufficiently low risk that they don't need it. And they exist for sure, because the actual risk is very low for most long QT patients. But we've got to figure out how to identify them with enough confidence that that there's comfort from the patient's perspective.
You raised a lot of important points, and I like to come back to several of them. So, what we're hearing is there are a lot of factors that influence your QT interval. And we didn't talk about medications. Of course, we're always reminding our patients to be careful about what another physician or healthcare provider might prescribe for your cough or your ear infection, because even simple antibiotics can sometimes be the factor that sort of takes your low risk situation into a higher risk situation. So I think especially for those patients who might need to be on other medications, the beta blocker adds another layer of protection. And what you say about the grandfathers as a role model is so important, because as you and I both like to say, we're really in the business of family medicine, treating generations with the same condition. Let's talk a little bit about how you've kind of managed the beta blocker challenges, for sort of with the reluctant teenager, the forgetful person, the curmudgeon. What are some lessons you've learned over time?
Yeah. So I think the first thing is don't rush into a decision unless you're worried in the very short term about something. So most of the people we meet are not in the hospital because they've had a cardiac arrest and can't go home without the protection of a beta blocker. 99% are in a clinic where they're identified because something happened or somebody in the family has something, and then this comes up. So, I seldom say, you need to take a beta blocker. I say, let's talk about making sure you never have a problem from long QT. Or let's talk about, after we have the results of your genetic test, for example, it looks to be like you probably have long QT, but be aware there's a few safety precautions of things, and then there's a treatment that's our usual treatment. And then, so it's a start the conversation, start the relationship type of thing, not a take your pills. Because I think that, our term for this is shared decision making, but the principle of saying, we're in this together, let's talk about this. And I tell people, if you say no and you don't want to take beta blockers, I'm okay with that. It's not like I won't like you or I won't take care of you. We'll take care of you. We want to partner, as long as you're okay with me bringing this up when we meet, because I think it's my role to try to make it as safe as possible for you. So first is start the conversation. So then the second thing is evaluate the risk, because the best medications for this are what are called non-selective beta blockers. So for people in the audience, this is Nadolol or propranolol. So if you like, these are the stronger drugs. So they work better, but they also, I think, have more side effects. They're more likely to contribute to things like fatigue, sleep problems, a little lethargy, some changes in exercise, and so on. In some ways, it's how they work. It's how they protect. They try to, not the fatigue, but they keep the heart from having adrenaline surges that cause events. And so people who I think are high risk are people who I advocate for that. People who I think are low risk, I would advocate that we use what are called selective beta blockers. So they're if you like, they're light. And so the light effects are a little bit of beta blockades, better than nothing. These are drugs that are less likely to have the same fatigue, affect asthma, those types of things. And my usual cutoff is that if they're over 500 milliseconds or their long QT has caused them a clinical problem, then we use the Nadolol and propranolol. If they're under 500 milliseconds and they're perfectly well, then we use bisoprolol typically. And we start at a quarter of the dose. So we don't hit them over the head. We try to ease them into it. A full dose, for instance, for bisoprolol is typically 10. So we start them at 2.5. And then after a month, we go up to 5. And then we repeat their treadmill test, because I was fortunate to start my career with a person who was a pharmacologist, a cardiologist who was a pharmacologist who did his thesis and his research on beta blockers. And I said, Jim, how do I measure if it's working? And he says, the only way to measure that is to do a treadmill test, because it shows you that it's changed how quickly their heart accelerates. And so we always do a treadmill test as part of making the diagnosis, and we do a treadmill test on the beta blocker to make sure that it's neither too strong nor too weak, that we have the right dose.
Those are very good practical tips, and also guiding principles, that it really is a conversation, and sometimes it's one that you have several times. The beta blockers, I think, people largely are familiar with them. What are some of the other therapies you've used in particular? Let's talk about the defibrillator. This does everyone with long QT of a severe type need a defibrillator?
Yeah. So I don't forget. I'm just going to mention that there are some things that are really, if you like, niche things that are, for instance, there's a drug called mexilotine that can sometimes be helpful in certain cases. There are things like making sure your electrolytes are okay. Some people will take things like potassium and magnesium supplements. The proof for these things isn't compelling, but sometimes it can be helpful. That's where, a person who lives in this space, this is the middle of their desk like you, Joe, are the right people to talk to about these unique circumstances. The different, I laugh, and so I'm a person who puts in defibrillators, and defibrillators are terrible things, but they're terribly helpful at the right moment. So I mean, this is an invasive strategy. They're not made for SADS kind of people. They're made for SADS kind of people's grandparents. Because they're not. We don't have machines, if you like, that are meant to be there and work for 30, 50 years. They're not that durable, because they have to live within our bodies and move and so on with them. So the defibrillator, especially in long QT, is a pretty rare event for me. It's around people where they've either had an event like a cardiac arrest and been fortunate to be resuscitated, and then it's their, if you like, it's their parachute. Or the alternative is that their long QT is so severe that I think the probability of that life-threatening event and then not surviving it is high enough that I think it's worth considering. And that's a pretty exceptional circumstance. And I think that's one of the things that we're learning is that the proportion of people who are at that severely high risk is very small. And one of the things that's happening in long QT in the research space is trying to develop sufficient information to be more accurate about identifying who's at risk.
I think that's a great segue into asking you a bit about research. You have led, countless studies and ideas and projects, and really have shaped a lot of the SADS research in Canada and definitely contributed internationally. Tell us a little bit about, at what point did you realize that, heck, if I don't pick this up and go with it, it's not happening. It's because, I want you to sort of take us a bit to maybe to HiRO, Hearts in Rhythm, which is really one of the, put Canada on the map, as it were.
Yeah, that's kind. Thank you. So, if I go back to how the story started, I asked, after seeing Derek and Trevor, I asked, well, how many patients like this do we have? And, back then it wasn't a very digital age, but when you combed through charts and looked around and those kind of things, we had maybe a dozen cases, pretty uncommon. And so then, a dozen cases is enough to get a sense of it, but not really either to do research or accurately describe it. So I said, well, for us to do this properly, I need other people I know to contribute. We need to create a multi-center, if you like, registry or experience. So, this was in an era where email was sort of coming out type of thing. And so then I emailed 3 friends. And so then we had 4 people and put in a research grant to Heart and Stroke, for example. And then 3 years later, we added 4 more places. And so now that network has grown into 25 clinics, including adult and pediatric clinics across Canada. And then that's been the forum in which to create a common experience for, and it started off around questions like long QT. And 2 things happened. One is, the most obvious one was long QT, but after that came ARVC, and then came family history of sudden death, and then came unexplained cardiac arrest, and so on. So, and each of these were sort of chapters of broadening the scope of people interested in families and cardiac disease. So this was sort of going along with a network of researchers, and Yishu, you were, one of the cherished in the early conversations of bringing this all to pass. And then about 10 years ago, I had this sort of epiphany where I said, something is missing. And the answer was, 12 or 15 doctors sitting in a room asking questions like, what do you do when somebody has a fainting spell and you're worried about it if they're on low dose beta blocker in long QT? That's a very good question. Okay. But what's missing is if you say, oh, well, I know exactly what to do. Well, then who are the people who deliver the care? How does that affect family members and patients being aware so that, in fact, this is actually something that's enacted? If I think I have the answer to the question and it's important, then we don't have a way in which this actually happens. So this epiphany was to say, we can't just be researchers. We need to be researchers who live and work with the people who provide the care and live and work with the patients and their families who are part of that team. So that's HiRO is the Hearts and Rhythm organization, which is essentially this intentionally messy group of people who don't normally hang out together, all under one tent, saying, what's important? What are the questions? What are the answers? And that's in part because I think if you're a patient or a family member, I think you want to meet a team of people who are curious, who are trying to answer questions and bring the best care to you. And I think that integration of researchers with care providers, with patients and families to keep the balance and keep the relevant questions at the top of the list is the best way that serves Canadians and the SADS community.
And, congratulations again. I think the 10-year anniversary of your annual meeting is next year, and Of course, the Canadian SADS Foundation was at the meeting this year in Quebec City, and it's a wonderful partnership. Why have you been so committed to Canada? Because you could have just as easily just called your community together from other countries as people also have done, and you were part of those other international groups. You've been incredibly patriotic in your building.
So I think the answer to that's two things. So one is I remember a long time ago when I worked in London, Ontario, I met some people who, when this started, and then you sort of build some research and a network and this type of thing, then people would come to see you from outside of where you live. So I would see somebody from other provinces and so on. And it seemed pretty obvious to me that, there were varying degrees of experts and teams that these people had access to. So one of my earliest goals was to say, everyone in Canada should live within a few hours of experts. Okay. So if you live in an underpopulated or small province, we need people in every place where somebody can go and see them and say, I know what you have. I know what the treatments are. I want to help you and your family, that type of thing. Because there's no way that I could see all these people. And the other thing is they're better served by local experts than they are by 5 places in Canada to go if you have long QT type of thing. And I'm confident. And one of the things that's important with HiRO is this idea of knowledge translation, that we learn, we define the expertise, and we try to scale it so everybody has access. So the nice thing in the last 5 or 10 years is we've gone from 12 curious doctors to about 60 physicians with interest or expertise in this area. We've gone from the odd genetic counselor to most clinics being multidisciplinary and having teams and having people with genetic expertise built in rather than going to 5 different places to get your care. So I think in that way, other researchers, everybody has to come to our center, including people flying from all over the place. And as much as they've taught us a lot about patients and families, it's been kind of come to me discovery. And I believe our healthcare should be come to you, let's work together. So that kind of patient and family messaging is important to me from the standpoint of impact on the population. Also because I think smarter people than me are very good at sort of discovering things, but they're not nearly as good as building systems to deliver them.
Yeah, it's as I say, it's fantastic, and the network in Canada has been, has really thrived. I've been, honored to be a part of it, and now at the meeting, you don't recognize everybody anymore, which is a good thing. In our last couple of minutes, I know you've also been very future facing, and I've been part of this on mostly from the sidelines, but watching with enthusiasm. Let's talk a little bit about what you see. I know also you've done work in AI and AI and ECGs and large language models. What do are you and I going to be obsolete in terms of the ECG in a couple of years? Or what are you excited about in that space?
Yeah, this is a very good question. Well, put it this way, would we know when we're obsolete? I put it this way. I think if you remember me saying that, before we had easy access to genetics and so on, and it was important to me, I was quite preoccupied with ECGs. I was pretty good at predicting whether you had long QT and also even predicting whether you had one of the 3 major types. And one of the things that's, some people listening will be people who have participated in HiRO-related long QT registry. We have over 1,700 patients in that registry from across Canada. And so what we did is we took the digital version of their EKGs, the digital recording behind the piece of paper that people look at. And we said, what's in there that helps to diagnose long QT? And we used let's call it advanced analytics, but the term is AI or machine learning, and said, can a more complicated analytic model tell us whether you have long QT beyond just measuring it? And can it also tell us which kind of long QT you have? So the good news is it's very good, and it's very good enough. It's better than me. Okay. And I don't mean that in a vanity sense. I mean that in an accuracy sense. And there are two key things about it that I think are important. First of all, it can pick out the genetic mechanism most of the time. And it's even accurate in the half of the people who don't have long QT on their regular EKG. It can look at the EKG and see things about the signal that's different, even when the QT isn't long. That is pretty cool. So this is now an open access thing. After we published this last year, this is now open access where a user can come and just drop a file and be told whether they think they have long QT and if it's long QT 1 or 2. So if you think about that, this is democratizing what you and I do, and does it at least for the EKG as well or better than we do. So I'm inspired by the potential for more accurate diagnosis and more available diagnosis. Right now we're working on integrating this across we've done the same thing in ARVC, and we're working on integrating this across the inherited heart disease spectrum. And I'm excited about the potential to enhance, on the one hand, to enhance our accuracy, our ability to treat patients very precisely, and also the ability then to scale that so that you don't have to be one of these people who are as focused on this, but it's available when you're in the emergency room, somebody's worried about somebody fainting, and can say, if I enter these parameters or I give this information to an analytic model, will it help me know whether I should be worried about ARVC or Brugada or long QT or something like that? So, and that I think that also feeds into our sponsors, quite frankly, which is, think of this, that our sponsors are looking at all the different domains of your gene and even your mutation or variant specific treatments, which is exciting because the more we know about it, the more we know whether those treatments are warranted, at what stage it is, and how accessible it is, and so on. So it's very exciting at this stage of our career. I'll lump you in, even though I know I'm the senior citizen, to see this degree of precision happening for understanding and treating patients.
Yeah, it's very exciting, and I think the AI is getting better. People are learning how to work with it and control hallucinations and things like that, and again in that space, working together, with I like your expression, a messy group of individuals. Suddenly we have the computer people at our table and other data people. Andrew, as always, it's a delight to talk to you. We could probably talk about SADS and all our queries for a lot longer. I look forward to continuing our collaboration and to seeing what you're going to do. I know you've got lots of ideas, and congratulations on your incredible success, not just sort of on paper, but what you've very meaningfully done for our Canadian SADS community.
Yeah, if I can be a patriot again and just say, one of the ideas that I had was many meetings rightfully start with a land acknowledgement because of our heritage and how we come to be where we are. And my proposal is that our meetings should start with a family acknowledgement. So I'd like to close with the idea that none of this can happen without a team or partnership with patients and families for identifying, protecting, caring, and supporting them. And they've given back with the research that helps us understand things like long QT and SADS-related conditions. So I'm very grateful, and it's really very rewarding to work with patients and families and see us making this kind of progress.
Wonderful statement, and I'll echo that. And it is absolutely a privilege to have those families put their trust in us and share with us and learn together. So that's our show for today, and it's been an absolute delight talking about long QT syndrome, and I'm sure many of you are familiar with it and impacted by it. Your patients are, your family members, and I really enjoyed and love the philosophy that Andrew has brought to this, including closing with that, a family acknowledgement. So maybe something we'll take forward for future episodes. So I'm your host, Dr. Shu Sanitani. Thanks so much for joining me, and enjoy the rest of September.